all of you who are joining us today. The topic is of great interest to the rare disease community, particularly in India. And we have two eminent speakers joining us today, whom we will hear from shortly, and there will also be a panel discussion. We want to give you a brief overview of today's agenda and what we will be going through today. I am Dr. Nisha Venugopal, the Associate Director at the Indo-US Organization for Rare Diseases. And on behalf of IndoUSrare, we are thrilled to have you all join here. And initially, we will look at a brief overview of what IndoUSrare stands for and our programs. We will have presentations from both our eminent speakers, Dr. Agnes Mathew and Dr. M. Pradeep Kumar. We will then have a panel discussion moderated by Dr. Kruti Varshni, and we will end with a summary and closing remarks by Dr. Reena Karta, the Director of Research Programs at IndoUSrare. We are the Indo-US Organization for Rare Diseases. We work to empower rare lives by bridging nations. And as part of our motto and mission to improve and accelerate access to therapies for rare diseases for patients and families worldwide, we have 6 key programs which range from research to education and outreach. We have a tech-enabled patient concierge through which we are able to provide personalized support to families that reach out to us from across the globe. In the few years that we have started this program, we have been able to support around 160 patients inquiries from across the globe, and this covers a span of almost 100 diseases. We have a coalition of patient groups from across the world who have joined hands with us as part of our Patients Alliance. These comprise over 65 groups from 4 continents. And these are the logos of all our prized and valued members. We are honored to be able to work with these groups to support the rare disease community. Our Corporate Alliance membership program allows corporates with an interest in rare diseases and a heart to support the cause to connect with us and be part of our mission. And through the Corporate Alliance program, they're able to contribute time and resources to support the 5 pillars that IndoUSrare stands for. We have various advocacy initiatives in the US, in India, and internationally in partnership with our DLA and responding to public comments that are requested from US FDA and other legislations in India as well as the US. We also have set up a working group towards generating an Indo-US blueprint for strategic cooperation for rare diseases. We engage in numerous research programs, which includes our research core, which is a growing network of experts, including geneticists, physicians, researchers, and various other specialists who all have come together to help us support patients and drive the knowledge further in the case of rare diseases. We also have various grant-funded research and education programs, including the recently published State of DEIA, Diversity, Equity, Inclusion, and Accessibility in Rare Disease Research, which was through a grant and collaboration with the Rare Disease Diversity Coalition, the RDDC. This is now available as a preprint on medRxiv and is currently under peer review. We are happy to share the preprint link for everyone to go through and invite feedback and comments and collaborations. This is a glimpse of the various works that we have done, which have resulted in peer-reviewed publications, white papers, and other reports. We undertake various educational and awareness programs, such as the quarterly webinar, one of which we are part of today. We, along with the rare disease community in the world, celebrate and commemorate Rare Disease Day and have a fireside chat series with legends. We have art and walk and run programs, as well as quiz programs to highlight the importance and improve the awareness of the rare disease cause, and our flagship annual conference, the Indo-US Bridging Rare Summit, where we bring together stakeholders from across the globe on one platform. Through all of our activities, we ensure, and this is key to our mission, to maintain transparency and work in a collaborative manner. We are proud members of the NOD, Membership Alliance, as well as founding members of the Global Genes Global Advocacy Alliance. We also have consistently maintained a streak of transparency through Candid's Guide Star, as well as our top-rated grade nonprofit through reviews from the community that we serve. A snapshot of our impact and a look at our collaborators and partners across the globe. We have 65 patient alliance members, around 5 corporate alliance members, 160 patients assisted through the concierge, all of whom represent over 500 rare diseases. And we have participated and hosted numerous global events, and we have multiple global partnerships. A snapshot of the new initiatives at IndoUSrare. We are working towards a Indo-US strategic blueprint that works towards building, furthering cross-border collaboration for rare disease research and orphan drug development. And there are 4 streams, and we invite everyone to sign up. The link will be shared shortly in the chat box be part of one or more of the working groups from you or your organization. The next meeting will be in the second week of July, inviting collaborations from everyone. The Bridging Rare Summit is scheduled for November 2nd through 4th. We welcome everyone to participate and be part of this initiative as an exhibitor. You can advertise your work in the souvenir. You can reserve a table for the gala dinner and donate to the cause and be part of a wonderful evening celebrating stalwarts in the rare disease community, and be part of the agenda by submitting an abstract to speak or to present a poster, as well as if you have an innovative idea for the rare disease community, apply to pitch your idea at the Pitch for Rare contest. Before we get started to the agenda for today and the session that we are all eagerly waiting for, a few housekeeping points. Please ensure that your mic is kept on mute so that everybody is able to enjoy and understand and appreciate the session. Please use the chat box to type in your questions, and we will read them out to the speakers as time permits. The recording will be posted online on IndoUSrare YouTube channel in case you have to drop out or you want to share this with your community. If you have any further questions, you can reach out to us at admin@indousrare.org. And as always, this is a platform for all of us to come together. Please feel free to use the chat box to share your experiences and interact with other attendees. Now over to our session. For today, as I mentioned, we have 2 eminent speakers on the topic of rare disease care in India, navigating inequities in access to diagnosis and treatment. The session will be moderated by our very own Dr. Kruti Varshni. She's a renowned and experienced healthcare professional who has worked with the rare disease community in India and has now completed her master's in healthcare administration at the Oregon Health and Science University, and she is going to take her support of the rare disease community to greater heights. And we are honored to have Dr. Kruti as part of the IndoUSrare team and as the host for today's webinar. Our speakers, the first speaker, Dr. Agnes Mathew. She is a consultant neurologist and a fellow at Pediatric Neurology, and she is a well-known face to the rare disease community in the country and everywhere, and she's been a champion for rare disease patients, especially those with neuromuscular disorders. And honored to have Dr. Ann here. Please join me in welcoming Dr. Ann to this program. Our next speaker is Dr. M. Pradeep Kumar, who is a consultant clinical geneticist based out of Coimbatore, and he's also equally accomplished and eminent with numerous achievements and awards, and has contributed greatly to the rare disease community, being part of various parent support groups and conducting numerous awareness events for rare disease, continuing medical education programs, as well as his own YouTube channel for the cause. Without further ado, I'd like to invite Dr. Anne to come forward and give her presentation. Over to you, Dr. Anne.
I think Dr. Nisha, Dr. Anne is having some internet issues. Would you mind if Dr. Pradeep can go in the order first?
Yes, of course. Dr. Pradeep, are you able to share your screen and present?
Yes, I can. Yes. Hello, good evening, all.
Good to hear, Dr.
Can
Pradeep.
you see my screen now?
Screen is visible,
Can you-
sir. Please mute
Yeah.
everyone. Thank you.
Okay.
Yes, please go ahead, Dr. Pradeep.
Yeah. Thanks a lot for this wonderful opportunity. Good evening, all. And it is just sharing our experience, what is happening in Tier 2 city of India. How do we go about caring for children with rare diseases? So they have unique challenges, as we all know. These disorders are chronic, they are crippling, and they need multidisciplinary care. Multidisciplinary care is that we have to ensure almost all the departments are there. You take any rare disease, it won't stop with one department. So we need a pulmonologist, we may need a cardiologist. But again, these families have to run from one clinic to other, and they have to stand in queue along with neurotypical children. So we planned, of course, initially, I planned bringing all specialties under one roof. And I tried it. It's worked for a while. But again, these cannot function as we expect, because only with rare diseases we cannot economically keep this going. So to care for rare diseases, we need an exclusive hospital for rare diseases. But again, this will not be cost effective, because the percentage of children with rare diseases is very less. And invariably, to run these departments, we need normal children also to come in, and that dilutes over a period of time. These disorders are progressively worsening. We sometimes the death is inevitable, and in front of our eyes, we stand helpless. Most of these disorders have no specific treatment, and they need supportive care and follow up. And this service is endless. There is a significant recurrence risk in the family and offspring, and we need to keep that in mind so that we can reduce the burden of rare diseases. And this also put this family into so much of stress. When they are planning next pregnancy also, that will be a big hurdle to come out of it. And because of this long-term care, and one person has to take care of the child, they have to run for health care. Most of the families are at risk for losing their job. They face financial struggles. And we would have heard about this social distancing only during our COVID period. But families with rare diseases, I could say, they are facing this for a long time. And you cannot see them in any social event, because they feel they are not right people to be there. 15 years back, when we started our practice, we had diagnostic challenges itself. We cannot make a genetic diagnosis from India. We have to write to some person who is doing some research in the corner of the world, and we have to wait for their response, and we have to send the samples. By the time we get the sample tested and the results, most of the time it would have been 3-4 years would have gone, because they do it on a research basis. But now the situation has changed. You name any genetic test, it is available on your doorstep. So next generation sequencing has revolutionized genetic testing, and also the same thing has happened in India. So we can do diagnostic testing in India relatively with ease. But the next big challenge was actually creating awareness when we started practice. Creating awareness not only amongst public, It was amongst the healthcare professionals also. We have to conduct regular continuing medical education programs. We have to go teach all the specialties, what all these rare diseases are about, and the care they need, the treatment options available, the prevention methods we have to think of. All these has to be put forward to the healthcare community itself. We have to go ahead and reach out the community, make the people understand in the next level. So we have to do marathons, we have to talk in FM, we have to talk in all social media as possible to create awareness. And I am running this YouTube channel, and I post videos related to rare diseases only. This subject, the Poralian Kadai, is the story of our friend Mr. Prasanna Shirol, Nidhi Shirol and family. And I've made videos regarding muscular dystrophy, particularly Duchenne muscular dystrophy also. All these are some platforms where we can create awareness amongst doctors and public. We cannot stop with that. We have to take care of these families and bring all the team of doctors under one roof and give them a multi-specialty camp at least once or twice a year, so that remaining time they can see the doctor separately, and at least once a year that burden will be taken care of. We brought Director Ram, who is actually taking so many films on rare diseases, and for one of our mass screening program. And Mr. Karthi, a known actor, was an ambassador for LSDSS, and we've made programs with him also. It won't stop with that. We've talked to even the health policy makers. To the right is our Honorable Health Minister, Mr. Ma Subramaniam. I've gone there, talked to him, put forward all the problems rare disease community is facing. So creating awareness won't stop with the families, the community. It has to be end to end, from the healthcare physician to the health policy makers. With widely available genetic testing, prevention became a reality. Later on, we started doing this prenatal diagnosis by amniocentesis or chorionic villus sampling. We can strategize the next pregnancy so that they get a healthy baby in the next pregnancy. So at least in this, I can say we can give some 100% results if we evaluate the index child properly. Pre-implantation genetic diagnosis is also very much possible now. But comparing therapeutic options, preventive options, genetic testing options are way ahead. But the real challenge lies in the management of the babies born. I know you can prevent this, but what to do with these babies who are born and they are struggling? It is not only the treatment, the management itself is very difficult. The management, I mean the supportive care. The supportive care is not uniform for all the centers. Even in a center where the medical equipments, medical facilities are far better than in any other town in Tamil Nadu, I face struggles in maintaining the uniformity of supportive care for children with rare diseases. So starting from neurodevelopmental, from the rehabilitative unit, from cardiac care, from the pulmonology care, there are so many lacunae I can see, because these people, the doctors, they are caring for normal children, normal adults. Along with it, they are caring for rare disease community. But over a period, once they start working with that closely, they'll learn that small nuances in managing our children. Till then, it is a big struggle for us. And again, treatment option, when it comes to treatment options, when you don't get a gene therapy, gene editing methods, initially something which gave us hope was enzyme replacement therapy. That is the intermediate product. That is, gene is defective. There are clinical manifestations. If you want to act in the intermediate level, that is the enzyme level, enzyme replacement therapy was available around 12 to 15 years back in India. So there were some charity access programs run by some companies. And with that, we had few children who had free enzyme replacement therapy almost for a lifetime. And I can say I was lucky. I had a family, and we started on Pompe enzyme replacement, and the baby had Pompe's disease. We know there is a significant history of risk of recurrence, 25%. We tested the next pregnancy, and the second baby was normal. The baby fortunately or unfortunately, was a boy baby, and the baby affected was a girl baby. I can see a drastic change in the attitude of the family once the second baby is born. They were very, very irregular. We have to call them and call for get the enzyme replacement. So over a period, they lost interest in the baby who was affected. Particularly, there is some gender predisposition also. Another child, a family who's fighting still now, child is 19 years old and he is on enzyme replacement therapy past 12 years. He is studying BCom now and he got this through charity access program. And without that enzyme replacement therapy, I don't think he will be leading this fruitful life. This charitable program was stopped. Previously, there was a board called Indian Medical Advisory Board to select the deserving patients who can get enzyme replacement therapy. But again, now we don't have anybody else to help us. We are dependent on resources like Center of Excellence, where they can give enzyme replacement therapy, but there is a cap up to 50 lakhs rupees they can support. This comes to around 6 months or 1 year of the need. But after that, what the family will do is a big question. There are other options like employment, state employment insurance, armed forces medical personnel, or crowdfunding. We try all these, but again, we are not successful all the time. The treatment, and particularly the crowdfunding, it attracts the interest of people, but again, that is not sustained. Treatment options for mucopolysaccharidosis were tried because enzyme replacement therapy is not available. It is not available continuously. It is given only for maybe 6 months or 1 year, but this family needs a long-term treatment. We have only recommendations for MPS type 1 where we can do stem cell transplantation. But again, all other MPS types, we don't have recommendations. But because of desperation, we have to refer them to hematologists who are trying transplantation with variable experience, variable success rate. But again, we are pushed to that level because we don't have any options. Standard of care, of course, it is not there, but we are waiting for some studies which will come up from India because other countries, they have access for enzyme replacement therapy. And the other challenge we face on day-to-day practice is giving the standard of care versus experimental therapies. Abortion for steroids is a good example. In spite of us telling them that this is a disease-modifying therapy, this is a relatively cheaper, easily accessible drug which can postpone the weakness, but the families have something in their mind. And there are so many WhatsApp groups running against steroids in DMD. I don't know why when we talk to them, when we try to convince them about steroids, they are not accepting. But I don't know why they easily go for stem cell transplantation DMD, which is not the standard of care, how much ever I know. So beliefs about native alternative medications are there. And I can understand all these are tried because of the desperation. And this desperation is due to inaccessibility to standard of care, inaccessibility to the medications which they need and they deserve. And this desperation leads on to exploitation of these families, and we face this in day-to-day practice. Crowdfunding, it worked for few families. I've seen even 16 crore was collected for one child. But again, that slowly went off because once they will give, twice they will give. After that, people will stop. Initially, it was a big sensation. Later, the response is poor. Some parents now, we would have heard of these adventures, that is crossing all the seas, all the mountains to get some parrot to save a child's life. A father will take that decision. I can see such fathers and parents. They are exploring treatment options across the globe. If the medicine is costly here, they are trying to get it in cheaper price in various countries also. For that, they take these children, go get registered there and get the medicine back to India. So to conclude, I can say the awareness related to genetic disorders, rare disorders is better. Diagnostic modalities are far better, and preventive strategies improving. People are, particularly the healthcare professionals, they are getting awareness regarding these preventive strategies. And supportive care, I would say it is there for a long time, but it is not uniform. Not all the departments will function in a uniform manner similarly. So treatment accessibility, it is very, very painful to say that we are in a very, very bad situation. Hurdles previously it was late diagnosis, but now the diagnosis is picking up. But after the diagnosis, what am I going to do with this child? The treatment is available, but it is not reachable to my child. Is so painful for the families rather than treatment is not available. Access and affordability to medication is a big issue now. So not only for the families, but also for healthcare professionals like us. Solution, we have to find some ways, and I'm very happy this parental organizations, they are going and knocking all the doors possible, and they go influence healthcare policy makers. They are finding solutions in different way, and we expect something should happen in India as well. Some generic medication should come up so that our children will get benefited. This is a child from one family. A child has Duchenne muscular dystrophy. They visit me every month, even though I say you can come 3 months once or 6 months once. They just want to see my face, get confidence, and go back. I don't know what to say. The confidence they have, I feel that responsibility. I don't know what to do with this child. He's managing now. The parents are enough motivated. I know how it is going to be, and I'm waiting something will turn up for this child. There are so many thousands of families waiting with some hope. We have to do something about it, and I'm hopeful these sort of meetings will achieve that. Thank you.
Thank you, Dr. Pradeep. We will now have a presentation by Dr. Ann, and after that, we will be able to get into the panel discussion.
Is my PowerPoint visible?
Yes, Dr. Ann.
So thank you. I'm going to speak along the same lines as Dr. Pradeep. We face the same difficulties. I thought I'll put it as an overview of saying, how do rare disease centers start? Usually probably starts with somebody like Dr. Pradeep or someone who's really interested in a particular rare disease. That motivation is there. And from there comes the idea that, we need to form networks. We need to have like-minded individuals of collaborative specialties. And then comes a satisfying and frustrating journey of accessing these elusive disease-modifying therapies. And that is why we're here. What is the way forward? So this is our journey in Bangalore. In 2018, September, at Bangalore Baptist Hospital, we started a rare disease center in collaboration with the Organization for Rare Diseases India. And this was the inauguration with the director. And this is one of the little girls now. She's grown up and she's become very big now. She's one of the recipients of the therapies. And so I'll move on. Our journey had started with the Shirols, with Mr. Prasanna Shirol and family. So I'm taking the example of just two diseases, two of the prototype diseases in the neuromuscular world, one being spinal muscular atrophy, which has 4 types, the type 1, 2, and 3, and 4. And as we know, as many of you might be aware, that this is a disease of the anterior horn cell, which causes progressive weakness. So I'm not going to speak about the depths of SMA. Instead, I thought, let's break it down to diagnosis. So here's a tale of 2 brothers. So 42-year-old older brother is whom I saw. So from age 14, both of them were progressively getting weaker. They were struggling to get a diagnosis, had 2 biopsies, had gone to major national centers. They were thought to be DMD because they had calf hypertrophy. Genetics for DMD was negative. Whole exome was done. And ultimately, they were mislabeled as limb-girdle muscular dystrophy. Ultimately, when they came, we did an SM and MLPA, and we got a genetic diagnosis of a late onset Duchenne of spinal muscular atrophy, which is a type 4 actually, because they were at onset was 14 years of age. So by this time, his younger brother, both are engineers, both are well-qualified, middle-class family, who live ironically just next to our hospital. The younger brother succumbed. He died without a diagnosis. And so this is the challenge of diagnosis for any rare disease. So this is a paper I've I picked up from thinking that this should be a challenge for all of us. China published this article saying this is their delay from, usually there's more, in any rare diseases, there's more than 8 doctors consulted, and the clock is ticking away, at least 4 years to diagnosis, and often misdiagnosed. But what is important here is I thought we should take it. They took it as 8 to 9 years is their delayed diagnosis, and this is a paper that was published 4 years ago. And here in this family for 42 years, and one person only after death we got diagnosis. So this is the first major thing, that we still have so much delay in diagnosis. So bearing into consideration all of these difficulties faced with rare diseases, and I thought when we look at India, eagle's eye view, we're a country with so many linguistic, religious, and racial diversity and geographical diversity, a population that accounts for almost a sixth of the world's population. Now, to say, it seems very ambitious to say we'll set up centers and have standards of care. So when we started in 2018 as a center, I was a part-time doctor there. I'm an honorary consultant there. And most of the individuals, I'm proud to call these my colleagues and these my team. And Dr. Pradeep also gets involved. We both are part of each other's network. So what we have formed is networks, and almost 50% of these individuals do not work in. Most of us don't work under one roof or one institution, but we are proud to call each other colleagues, and that is what we are hoping to lend to our patients. So disease-modifying therapies is a new dawn. And so taking SMA again as an example, we have gene replacement with onasemnogen abipavir, and we have SMN2, making SMN2 gene more effective with splice site modifiers such as nusinersen and risdiplam. But underpinning it all is the standard of care, which as physicians we know, but I echo Dr. Pradeep's sentiment of this feeling helpless when we're telling, why can't they listen to us and take steroids? Why can't they listen to us and do things? And it's not a question of that. It is, while we are walking this chronic long journey with families, we do understand their pain, but ultimately what underpins it all is SOC, but it's so difficult to deliver. So for us, in many ways, we already had, before the newer disease modifying therapies came to India. So our first taste was in 2019, but before that, luckily we had started our center a year ahead. And then along came the NGO called as Direct Relief, and they had decided to donate Spinraza, nusinersen, to individuals in India. And fortunately, due to their help, almost 200 individuals are getting lifelong Spinraza in India. And initially, 4 centers were selected for the north, east, and west and south of India. And all of them, as you can see, were government hospitals. All India Institute of Medical Sciences came, Mumbai, SGPG, Lucknow. We were the only private center. That was Bangalore Baptist Hospital. There were 144 applications that went out, and we were given 2 weeks to apply. And of the 144, the vast majority of it came from our center. So this is after getting Spinraza, one of our children, we had around 26 that were selected. One of them, in 3 months, he's a type 3 who lost weight because he was so much more ambulant. So this is another of the medication that's available in our repertoire of medicines for risdiplam. But again, the only drug that is registered, that is 25th of August being the date that it was registered in India. But still, there's such a long distance before it becomes available to children with SMA. And of course, the third entry into this, or the earlier entry in between, which is which is not yet licensed in our country, the so-called one-off gene therapy, which is 16 crores, the $2.1 million US drug. So this was on 21st of January 2021, which was incidentally the 21st day of the 21st century, or the 21st year of the 21st century, when we were able to give our first child with gene therapy. And we went on to be the fortunate recipient of many children, almost 27 children who received gene therapy free of charge through the Global Managed Access Program. And so disease-modifying therapy, shiny gadgets, shiny medicines, DMTs aside, we'll come to the story again of another child, a little girl who presented to us in 2018. This is before we had any of the shiny medicines. She came to us, she's the only child of her parents, with 6 to 8 LRTIs, pneumonias a year. After a lot of talking, the family were convinced to start BiPAP. She improved. She had less admissions, so they were convinced. But she had persistent failure to thrive. Again, we managed to get the family to agree to gastrostomy fundoplication. For over a year, she was free of lower respiratory tract infections. Then what happened was she was fortunate enough to get selected for Spinraza. She got it, she became stronger. But by this time, this was winter time, she got RSV bronchiolitis, was admitted to a children's hospital, got the best of care. She took 1 week to recovered, got discharged. Immediately within that same day of discharge, presented to us in acute respiratory distress and shock. She was not sick, she was not infected. It was just the effort, the simple effort of having poor respiratory clearance, not being able to clear her airways, which landed her in this trouble. Unfortunately, we are a busy hospital. We did not have beds. We did not have a free ventilator. So all we could do was give her plenty of nebulizations, increase the pressures, and managed using her with cough assist round the clock, hourly, and rapidly. By 12 hours, she was fine. She shifted out of ICU and she was discharged home. So these things are the things that make a single most thing that makes a lot of difference to our rare disease community, our weaker children, the BiPAPs and the cough assist. And of course, the nutrition. So this is another child who was a recipient of the gene therapy, but who would have died but for this, because this is a child, she was only 4.7 kgs, and this is a photo that was taken when she was 2.2 years and 4 months. And so we had to motivate the family by saying, okay, look, keep looking at this picture, keep giving her good nutrition. And this is, she's then put on weight, and then she gained milestones from the gene therapy only after she gained weight. So I'll briefly touch upon the DMD. So DMD, we all know, grim reality. They all survive. We have Indian literature which says average age of survival 15. But when you look at Western data, what they have been looking at is that progressively, they speak about DMD in America and in Western countries in the 70s to the 80s to the 90s. They're talking about spine stabilization surgery. And now they're talking about, and all of this difference has changed. And now they're talking about the fact that you're pushing boundaries, they are living longer, and nobody's mentioning scoliosis here. So this is something that we need to aspire to. DMDs, if they get scoliosis, it is a failure on the part of all of us as clinicians taking care of them, as advocates of rare diseases taking care of them. So making them, have decent, good bone health should be able to prevent scoliosis. And steroids are the single most important factor, where people are living till 45, and the oldest person lived till 54 in France with just these things. And the goals to improve life expectancy and quality of life would improve steroids, but doing it carefully, improve cardiac care, preventing scoliosis, not treating scoliosis, preventing, proactive, not reactive respiratory management. So this is a summary of what we are doing. Over 1,000 neuromuscular patients, over 600 SMA, 600 DMD, more disease-modifying therapy in the SMA sector, 34 gene therapy, 40 risdiplam, and 26 Spinraza, and 13 children who are getting the Exondys, that is the eteplirsen, and 2 have missed out, 2 on atelurin. So turning burdens, we saw the burden, we are only seeing the tip of the iceberg. So much of that burden is hidden behind, which we as clinicians, however motivated we are not living with this for us to unpack. But I do believe that with many of these qualities that are mentioned here, we can unpack them. So when we looked at this program, this was something that we had presented, is that we have a higher degree of consanguinity, we have higher genetic diseases. So there's such a gap in us. If you take DMD itself, life expectancy of 15 versus so much more we are lagging behind in care. So the obstacles that our patients have to, I'm reiterating what Dr. Pradeep said, is diversity, challenge of limited resources, health resources, self-funded care, lack of awareness, social stigmas, and there's such a paucity of experts or quaternary centers. And of course, underpinning it all is the delayed diagnosis. So these diverse, complex issues, I'm going to rely on age-old wisdom that we have, saying that our ability to reach unity in diversity will be the beauty and the test of our civilization. So this is something that we have proposed and we have been a part of. Dr. Pradeep too has been a part of this, of conducting mega OPDs, single disease specific mega OPDs, as a way to build up low middle income countries to how to deliver these kind of specialized comprehensive care for rare diseases in geographically diverse settings. So this is our 15th camp. We just had our recent 16th camp in Bangalore in Baptist. This was in Chennai. So what we did was we thought we can collaborate with parent organizations, disease specific, deliver standard of cares, multidisciplinary team, and we have a local lead clinical physician who can then lead this community, and there's a ready-made group who can support each other. So start to finish, what it entails. So physio, various specialties are involved. And the advantages is that delivering SOC to large numbers of just one disease, MDT under one roof, minimizing delays, networking among the advocacy groups and the specialists, and encouraging long-term follow-ups, reducing financial burden and efficient use of resources, helping create registry, and then training other healthcare professionals. That would be the goal of this kind of a model. Now, this is something that we've been doing for the last 3 plus years, 3 years and 2 months. We have been running monthly specialist online sessions on the final Tuesday of every month, where we have speakers speaking on only neuromuscular disorders. So we believe this is our contribution to improve our network locally, not only in India and almost Southeast Asia. We've got clinicians joining us from Afghanistan and Pakistan and Bangladesh, as well as Sri Lanka and Nepal. So that's it, my bit. Thank you.
Thank you, Dr. Ann. That was indeed a very enlightening presentation, and I can vouch for all those seminars that you have been conducting on monthly basis. They are indeed very knowledgeable to all of us. And I also thank Dr. Pradeep for the wonderful presentation. We all have known that rare disease present with its own medical challenges and the various challenges that both speakers have discussed. But yes, amidst these complexities, I'm sure there is progress, innovation, and unwavering commitment from clinicians, families, and advocates. And you know, as someone has rightly said, I think in the world of rare disease, every patient is a pioneer, and every small step forward becomes a milestone for many. So I am honored to join by these two incredible experts having this conversation, not just with the lens of inequity, but with the belief that equity is achievable through dialogue, action, and shared purpose. And I once again urge the audience that if you have any questions, please post in the chat box and we'll be happy to take it while we are having this discussion. Let me start my conversation with the fact of the national policy of rare diseases, which was a big milestone in 2021. And so this is one of the very important topic nowadays in our discussion. And I would like to hear from any one of you, Dr. Ann or Dr. Pradeep, from your clinical vantage point in a smaller city, which parts of policy has improved the care pathway or access, and which parts of policy have not? I mean, I just want to have your experience practically on how has this policy changed life of a patient.
What do you want to say, Dr. Pradeep? Do you want to go first, or what do you want to say? I'm not sure.
He's waiting for you.
Okay. I'm not sure. I can't say it hasn't helped. Most of the time, it doesn't directly help us. Oftentimes, it seems like it is making our life miserable, the policy change. Because somebody's made a policy, some people feel like they have to act on it. They don't come up with realistic solutions. They just act for the sake of acting, and it just creates more nuisance than anything is worth. But I still feel it is still a step in the right direction, because a lot of stupid noise is made. As in, we get random phone calls from some Ministry of Animal Husbandry or so, things like that, telling you have to give this child the best care. But what is the best care is left up in the air. There's nothing that's defined. It's just it almost feels like a threat that is made. But while be that as it may, I still think it is encouraging, because when all this talk is happening, we're still a democracy. People are listening, people are watching. So the minister, who may or may not, or the health or the individual in power might not realize it, but if he is being forced to articulate it, it means other people are listening. Other people are saying, oh, by the way, this is there. And so as many people, and I still encourage people to say, go, this is there, go, ask, keep asking again and again. And while I have not actively seen the change, but I can assure, from at least from my practice, that including something as simple as standard of care, 10 years ago, the difficulty, or even 5 years ago, the difficulty I had in convincing for steroids is not there today.
Yeah.
People are a bit more, it seems like our job is a little bit more easier every year than it was before. But having said that, when we feel that thing is easy, then when you're easily managing, you get more difficulties and something else that's more complex. That's a different story. That's a bandwidth. Yeah. I don't know. What is your take, Dr. Pradeep?
Yeah. So the rare diseases health policy wise, the 50 lakhs the patients' families they get, that is a big achievement. That is a big milestone. But the thing is, again, these are not enough because we know what the cost of medications are. And initially, it was released only for one-time surgery or one-time treatment. It's like bone marrow transplantation, you can do and get away with it. It was not released for medications, for the ongoing treatment. Now there is a little bit of leverage. You can use it for 50 lakhs can be used for medication one by one also. Every month on, you can get the medications. That is there. But again, government giving 50 lakhs, particularly from India, giving itself is a big thing. But again, they will not know. No, our problems are different, unique, and we have different sort of problems. Making them understand will take a long time. I can understand. And another thing, another milestone I can consider is center of excellence. So trying to establish center of excellence is a good idea. The issue comes again, the same people who are working in elsewhere are put into the center of excellence as decision makers. So that becomes the difficulty. We think we can achieve something, and there will be some pessimistic points towards managing these children. So they will give their information to the health secretary or health minister. That may not be the same as what we think. So we will want to try everything. We won't leave any stone. We won't leave any stone. But again, they will think that whether this will be useful in the long run for a child before recommending. So it is difficulty. There is a difficulty to push these people who are sitting there also, make them understand that these are worth in a long run. We can do some wonders for these children. These are difficulties. So positives are there. Of course, there are few challenges which we have to address.
I completely get to your point, Dr. Pradeep, and I'm going to just dig a bit more on that, on your interactions with Center of Excellence. I think you work that interactions between the Center of Excellence and other hospitals. What is the best way to make it more smoother, more effective, as far as from the lens of National Policy of Rare Disease is concerned, or from any other perspective? How can that interactions be made better?
It is very difficult to reach them. So first thing is making that interaction possible. That is one thing. Next thing is people keep changing. So I'm sitting in my clinic, I'm sitting in Coimbatore. You go see Dr. Pradeep for genetic disorders. There is no. It is not so one person. Go to Dr. Ann in Bangalore. It is over. You can find out and go. So and over, if you need somebody who should be there to grow the department. It is not like you sit for 6 months and go away. You will also don't feel that this is your home. You have to grow. It is like it is just a temporary place where you won't put your mind and heart into it. So I am facing these challenges. One is interaction is less. Another one is people keeps changing. Another thing is they are not growing from the grass or from the same department or who echoes our emotions. And from their point of view, the pressure they face, I feel, is their hands are also tied. It is not that they cannot take any independent decisions. You can force them to write some rigid plan to a child, but there will be thousands of questions for them. So it is we always think that person who's taking care of center of excellence has all the power. It is not like that. So they also have some pressures which they will not express to us, which cannot be told in public also. In their point of view, I see there is a hurdle there.
I like the fact that you have presented both the sides of the coin, Dr. Pradeep, and I completely understand that for a better standard of care, this is one of the important bridge to be, built upon. But moving forward to this, I have a question in the audience from Dr. Harsha Rajasima, who is one of the pivots for IndoUSrare. He's asking if you, both of you or one of you, can elaborate on patient registry systems and the importance of patient registry in the country for rare diseases.
Dr. Pradeep, this.
Ma'am, can you comment on the issue of lack of exact
No,
number of people,
I'm asking, can you elaborate on the patient registry systems and the importance of registries, patient registries?
Very, very important. So again, center of excellence, there is an advantage. We have to invariably go and register. That at least is happening. So I have my own register. Dr. Ann will be having her own register. So many other doctors will be having. There is no way we can put it together. It is very difficult. I can say it is very difficult to put it together. Maybe government has made it a must that they have to go get registered. At least there we will get some registry will be there. So the registry definitely is a need of the hour. It's been there for a long need of the hour. We are telling it has been there for years, but at least center of excellence, we are registering some patients. Madam?
So the thing is, I have a problem with just what is called as a center of excellence. We are such a big population, and we have fantastic apex institutions, government-run apex institutions, but there is absolutely no match at all to the population. So it is not possible to call that only a center of excellence. The government should have some way of recognizing either some charitable trust or anybody that is delivering. So a good example for that is when we had the Spinraza drive. When they had said only center of what at that time they didn't use the term center of excellence because this was in 2019. And that time they said they picked what is currently today the center of excellence is the 3 centers. And then when they approached Bangalore, the National Institute, they refused because it was a lot of work doing it. And ultimately, of the 144, more than 110 were our patients. And we did not even have full-time doctors. I was not full-time. Everybody was part-time in that center. And all we did was, and I must confess, we saw patients only for 7 days because I could not take that many days off. And all we did was we extended our hand and got volunteers from all over who helped us in run these center services. All I'm saying is that there's a lot more red tape and things with the Center of Excellences. If there was some way to collaborate, all that it is doing is we know our colleagues in government institutions and institutes, they are doing a great job, but they are under a lot of pressure. And so they have to work within the limits that they have. So most of us have to work within our limits, but some of us may think, okay, this is my passion. I like DMD, I like SMA, or I like CDKL, or whatever, or ERT, or enzyme, or lysosomal storage disorders, and I want to work more in that. And we have the flexibility to make the decision. So there should be some criteria for including and collaborating that, because now it becomes us against them. So when it is, and on both sides we are friends and we are working towards the same goal. So instead of solving, it is more a punitive system where you are discouraging people who you're named as a center of excellence and telling them, beating them with a stick and saying, look, you didn't do this. So for example, SMA, as until recently, the registry that is very important has only 10,000 people. Whereas we know from population, projective data, if you take Western data of incidence and apply it to Indian population, we ought to have 2 to 3 lakhs of SMA. Of the 10,000, what they're calling is how many people applied. So we have 600 patients. So that is just us, one center. But we're maintaining a registry somewhat. So like that for all of us individuals. What he said, I don't know how we can go and maintain a registry when I'm sure half of them are not even diagnosed. They may just be dying before they get diagnosed.
Later.
So the only way this is the way I'm seeing it, rather than just the registry is a good idea, is if we can get funding from some source and sample 2 taluks. I'm not saying districts. 2 taluks, one of a consanguineous, highly consanguineous area, and another of a traditionally non-consanguineous area, and say we sampled everybody, did a PCR on them for SMN genetics, or SMN MLPA, or PCR for SMN copy numbers. And then we say, okay, this is our incidence in this community versus that community. Consanguineous versus this, then we at least have something to extrapolate for India. Right now we have nothing. And then you go to a minister, you ask, or somebody in the government and ask them, please help us. And they say, okay, where's the registry? Here it is written on a sheet of paper, it's 10,000. Say, jao. 1.4 billion population, 10,000.
Yeah, I think right now whatever we have is all very good start. I think we are going in the right direction, and now we are understanding the nuances, right? I mean, what are the hurdles? What are the opportunities? and focusing on the opportunities and going forward would be and I think this idea of doing focus studies in 2 taluks with specific background, consanguineous versus non-consanguineous, that's a very good idea. And I guess we should just think how can we make it practical?
Yeah.
Mhm.
No, I think I also feel that consanguinity rate, specifically in the 2 states that you have been working, have been higher. And so the SMA rates have also been higher. But I am seeing a change in the patient's perspective from that rates also. They come for preconception counseling and, prenatal counselings for such things. And yes, but, I'm gonna piggyback on that point of view, Dr. Ann, of your diagnostic part. And someone has a question in the comments that, can you comment on the issue of lack of exact number of people affected by rare diseases in India? What is a concrete and a practical solution to this issue, which is affecting many other patient communities in India living with lesser known conditions?
So the only way of doing this is by improving medical education. The good commentary is a child I saw today from Sikkim, a village in Sikkim, who had CDK, chronic granulomatous disease. First child diagnosed, regular infections, died. By the time they sent genetics at 2 years, 5 months. By the time genetic report came, child died. Second child, 7 months, same presentation. Parents pushed, got diagnosis at 7 months. Got a bone marrow biopsy, but they're in Bangalore. They're not in Sikkim. They had to leave Sikkim to come to Bangalore. And the father sitting in front of me and crying, saying, why was I not told that this could be prevented? I'm sure this is the same Pallavi that all of us are hearing. But what we'd have to understand is the geographical diversity. This man, to understand this man, he is in the CRPF, Reserve Police, Central Reserve Police. Because he's in the CRPF, that made him somebody whose child could be diagnosed. He had access to care. Another Sikkim citizen will not have that. There would just be a child who died and 2 children who died. So it was interesting that he said they don't have the consanguinity, but they're from tribes. He said, like we have Gotras, that tribe was not supposed to get married to that tribe because they consider themselves clans, same clan. So he was not supposed to get married to his wife. So there is endogamy there. And he got married and he has 2 children that is affected. But he is upset. His child is better and child is getting well, had 1 year post-transplant. But so the answer is there. Answer lies there. So geographically diverse, how do we make diagnosis accessible? I guess we have to tell pediatricians that, CP is not CP. Have a higher degree of sensitivity. You see microcephaly. You see children who are not behaving the way they are. Child with a cough or a cold that is going on, coming back to you, and not getting better. You pick up and throw it back to specialists. What else can we do?
Yes.
Because here, we all live in our ivory towers. I'm a purely referral doctor. You're a referral doctor too. Those who come to you for pre-implantation genetics are not the people to preach to. It's those who are
Yes.
not at all aware of pre-implantation genetics. They're the ones to reach to. And how do you reach them? So I don't know. I'm hoping others would have answers to it.
No, that's so true. And we're
think-
sitting in the ivory towers, but you have been doing the medical education part from your model also, the disease specific mega clinics model. I'm sure there will be some part of it. But I think we are with a ticking time right now.
Kriti, I think we can to Dr. Ann's point, I think we can take Dr. Harsha's question. So
Yes,
what
I was just
opportunities
gonna
do you
say.
see in fostering India-US collaborations, especially when it comes to education or research or things like that? How do you foster that collaboration for a disease community?
So this is where somebody like Dr. Pradeep also comes in. We have to, the only way of doing it is external force, not internal. So
Yeah.
we are very well known known to each other. So for example, Dr. Pradeep also has friends across, and I trained in UK, and now we've got a center with a large enough number that I know that my colleagues in the West are jealous of us a little bit. And jealous is a strong word, envious. So they are keen to work with us. So if we foster, we gain some of their know-how. So for example, if you have to do a trial for something as simple as eteplirsen, in a country like Copenhagen, you would get no subject.
Yeah.
Used it all up, exhausted. Whereas we have hundreds and hundreds. I mean, our center, I myself have more than 120 patients for that one disease medicine. We have not, and that is seen by the fact that now US is looking at us. So companies like Sarepta, US-based countries, they had a problem with India and the way we were managing research. But India is being seen as an option.
Yes.
So clinical trial is
Yes.
the way forward. So when we
Yeah.
talk to each other, and that means we have to, Dr. Pradeep and people like him, we have to make an effort to go to the international conferences, targeted conferences, because
Mhm.
we don't have unlimited budgets. Nobody else pays for it. So people like us, I earn so that I can go for the conference. And then
Mhm.
when we go for the conference, we make ties and collaborations with those people. Research comes, they come to us, we go to them. Then
Yeah.
the government also sits up and watches and say, okay, this is doable. And something might come.
Yeah.
What do
Yes.
you say, Dr. Pradeep?
Yeah.
I think I don't know whether we have messed up the previous opportunities. Whenever I write from India, I don't get any reply. Any trials anywhere from abroad, not only from US, anywhere you write, no takers for us. So
I think
for these rare clinical trials, GOE.in and all, there are so many trials will be running. We have so many patients. I mean, and there is no way we can connect the trial and our needy patients.
Mhm.
Sometimes I
can
used to
connect.
tell the families, you go right to them. At least let them respond to a patient like you, maybe not the doctor like me there. So previously there should have been some mess which they know that we are not doing it right. Maybe it's the right time for us to correct ourselves.
I mean, I think that is what Dr. Ann was also mentioning. I mean, I think that trust in the trials being done in India, the lack of integrity or quality standards and things like that was the challenge. And we are trying to change the message by doing these webinars and all that to let the world know that now the hospitals and the institutes in India are coming forward. I mean, they are maintaining the standards that are required for the Western world or for the FDA. And we are able to do that studies and maintain registries and maintain data, collect samples the way they need to be collected, store them, handle them properly. All that is possible. And again, these are platforms where we want to, again, resonate that message so that we have more stakeholders who would trust India, basically.
And
Dr.
you
Pradeep,
know,
sorry,
please
just one.
go on, Dr. Ann.
Pradeep's echo. Dr. Pradeep, writing does not make any difference. They have to know you to trust you. So that is where you're physically choosing to go to the conferences, and
Mhm.
them seeing your work makes a difference.
Yeah.
So it's now only like what, 6 years, as I said, since we started, 7 years since we started this. It's only 2 years ago that we started doing international trials. And now I feel like, okay, reach somewhere that one of the 60 sites for one of the trials that we are conducting is my alma mater, Great Ormond Street Hospital, London. My previous boss is one of the PIs for it. And we are also on the same page.
Yeah.
And by the same token, what Dr. Pradeep said, when we submitted a paper saying this is 25 years ago we submitted, only now we got accepted, saying this many data, SMN patients, at that time we had 200, can we publish? They outright rejected us within 24 hours saying, we don't believe you, you can't have this data. So this time when we submitted with one of my colleagues from UCL who's a well-published art professor. So it got accepted. But that's the first step. They're checking our validity, our provenance, the data that we are giving, and then we're establishing trust, and from there we build. It's a slow
Yeah.
progress, slow process, but it will
So,
work.
yeah, but I think the yearly conference of IndoUSrare happening in November, this time in US, will maybe a starting point also. So it's a conference where everyone from biopharma, from research world, and clinicians will be there. So we'll be happy if any one of you can be a part of it. But this was indeed very enlightening from both of you. I know there are still one or two questions, and I'm sorry we are at a closing time, but we will get back to those questions offline. And I'll invite Dr. Reena to please propose the closing remarks, and so that we can wind up with this webinar.
Yeah, thank you, Dr. Varshney, for such a good discussion and for moderating this session, and Dr. Ann and Dr. Pradeep for enlightening all of us about your experience from two different cities. And for the audience from US, I just wanted to sort of compare the cities that you come from. So Dr. Ann is from a city called Bangalore, which would be similar to like a private hospital that is existing in one of our cities in the US, like in San Francisco or in Minneapolis, I would think. And Dr. Pradeep comes from an industrial city called Coimbatore, which would be similar to Columbus, Ohio, or maybe Austin, maybe a little smaller than Austin. So yeah, a hospital that is based in Austin, Texas. So the resources are
comparison,
very
Reena.
different. Pardon?
Good comparison.
Yeah. So I mean, so I just wanted to highlight like the resources that they work with are very different. And today what we wanted to portray is their viewpoints, their perspectives, treating these patients. And you can see the passion that they come with. They really want to help this families, these patients, and they're trying to do everything they can possibly do to bring care and help them help manage their condition. And we want to hear such voices more and more to understand what are the opportunities we have to make this better. I mean, I know the policymakers, the government, they're all trying to get to that same goal. The pathways may be different. The challenges are there, which is not where we don't want to say that there are no challenges, which is all real challenges. And everybody has to voice their, concerns as well as their opinions on how to make it better. And only then we can bring treatments for most of our families. And as Dr. Ann mentioned, India has a higher number of individuals who are affected by rare diseases than rest of the world. And we should be part of the international clinical trials. We should be able to collect the numbers. I think there was a question about how do we assess the prevalence of a disease. And I know we have done, IndoUSrare has published, I think it was last year, an article on how do we come up finding these numbers of individuals who are affected by a rare disease? How do we come up with prevalence? So please, I would encourage you to look up that article. And I think it was published in the Rare Disease and Orphan Drug Journal. So we have provided like some examples on how we can best calculate the prevalence for rare diseases in a country like India, where we don't have a standard registry. So again, I would like to invite all of you to be part of our summit that is happening in November. And please join me in thanking Dr. Ann, Dr. Pradeep Kumar, and Dr. Kriti Varshney for this wonderful session. Thank you. Nisha, is there anything else I need to add? Or if I've missed something, please jump in.
Thank you. Thank you, everyone, for joining us, and thank you to our eminent speakers. As Dr. Kriti Varshney mentioned, this call is being recorded, and we will get your questions to the speakers and try and get you the answers as quickly as possible. Thank you for staying 10 minutes above time, and we could go on and on, but then all good things have to come to an end. Thank you. Good day and good evening to everyone.
Thank you all
Thank
for
you.
joining. Thank you so much.
Thank you. Thanks. Bye-bye. Bye.
Thank you, Dr. Kriti and
Bye.
Dr. Leena.
Bye.
Thank you for having us and inviting both of us.
Sure.
Thank you.
Always a pleasure, Dr. Ann and Dr. Pradeep, you too. Bye-bye.
Mhm.